Good morning and welcome to our 36th edition of Global Healthcast, brought to you by Global Health Press. In this podcast series, once a week, we bring to you news and views about infectious diseases, vaccines, and vaccination. Today is May 2nd, 2023. I am Joe Schmitt, and with me is Dr. Melvin Sanicas. Good morning to Switzerland. Good morning, Melvin.
Good morning, Professor Schmidt, to you there in Germany, and good afternoon and good evening to others who are watching us from different parts of the world.
The topics today are, as always, COVID-19 update, including the variants. There is a monkeypox case rise in some Asian countries. We cover why infectious diseases will increase in the future, the criteria for the development of new vaccines, and evidence generation for the development of new vaccines. And then Melvin will give you an update on most infectious diseases, and today he will cover Rift Valley fever. Melvin, let's start with the COVID-19 update. What's the news? I saw already it is gone, right? We are safe.
Yes. So if you look at this, obviously, if you compare it to the previous years, we are definitely in a much better place. But it doesn't mean that COVID is gone, because 2.8 million cases were recorded in the past week, and over 16,000 deaths were reported as well. And this is actually a decrease of 23% and 30% respectively. But yes, there's still COVID spreading, and contrary to the overall trend, increases have been reported in some countries in Southeast Asia, in the Eastern Mediterranean region of the WHO, and in several individual countries elsewhere. And it's also important to remember that these cases reported are most probably really underestimates as shown in prevalence studies. And this is partly due to the fact that people are not testing as much. There's delay in reporting, there's delay in testing. And we should really just keep in mind that the data in this report, they are incomplete and should be really interpreted with caution.
So overall, good news, but the last word is the important one. We have to be cautious. The organism, the virus is still around. And there are still cases. And actually, what are the number of cases?
Yeah, so if we go to the next slide, which will show us the number of cases, you will see that at the country level, the highest numbers of the 28-day cases were reported from the US, from the Republic of Korea, which is South Korea, the Russian Federation, Japan, and France. And I have noted there, just to compare with the cases last week, so the number 4 and number 5 country is now Japan and France, but last week it was France and Brazil. So there's a little change there in terms of top 5.
And how does this relate to deaths?
So if we talk about deaths, the numbers are sort of similar from last week. And the top 5 are, again, the US, Brazil, Russia, France, and Iran. And last week it was actually Germany that was there, but apparently this week the numbers have improved for Japan, for Germany.
So contrary to the morbidity data, I think the mortality data are probably more reliably reflecting the situation, because death is something very hard. And death is something where you try to find out, why did this person die? And there are more efforts. And the incidence rates, they are soft data, because, the number of tests changes, and who is tested. I mean, all these items change all the time. So the incidence I'm not so sure about, but the death toll, this is something that is a pretty good number, I guess.
I agree.
Yeah. Very interesting. So I'm happy to see I'm safe here in Germany. We are no longer on the number 4, on the highest number of 28 days deaths. So very good news for me here. Anyway, and how about the variants that are observed?
Yeah, so the variants, as as a quick reminder for people, so we have the variants of concern on the top, then we have variants of interest, and then we have the variants under monitoring below. And in this table, also from the WHO, you will see that among the variants under monitoring, so we have XBB, XBB 1.9.1, XBB 1.9.2. You will notice that the names are sort of similar, right? Because they are related to each other and only have very few differences in terms of mutations. And they are increasing, but the others are showing a declining trend during the same period. And if you look at this table, you will see the highlighted parts are the ones in orange are increasing, and the ones in green are the decreasing variants under monitoring. So, I mean, what we can say here is just there are variants circulating. Some of them are increasing in terms of numbers reported, and some are decreasing, and maybe they are competing.
Very interesting. And I think this is something we will continue to monitor. Like for influenza, we keep observing the different H and N types. And I guess this is for the coronavirus, for SARS-CoV-2 virus, the WHO will continue to monitor the variants, right?
Yep.
Yeah. Very interesting. Melvin, I brought a story that is not much news, but I guess that is more about insights, about my expectations for the future. And I think there are three reasons why infectious diseases in the future will increase. And the first one is there will be more microbes. And there will be more microbes because the number of humans increases. And you see this here on this slide, and I apologize, it's too small to be seen. But when Christ was born, zero, right? The year zero, there were 200 million living on the globe. And with time, today is 2023, we have almost 8 billion. So this is a huge increase. It's an exponential increase ever since the 18th, 19th century. You see this going up. The number of humans increases, and with the number of humans, we have more cattle, more swine, more all types of animals we need for our food. And these animals also harbor many, many organisms. And as you know, some of the infectious diseases, some of the most common infectious diseases are foodborne. And finally, the climate change favors geographic expansion of some organisms. So again, there will be more microbes and we will have more exposures to microbes. And this means there will be more infectious diseases just because we're more. If you double the world population, you have twice as many infectious diseases, everything else being the same. The second reason why I think there will be more infectious diseases is there will be increased exposures. And the reason for that is largely due to travel. What you can see here, when Christ was born, we were walking, or we had horses, or some people at least had horses or mule or whatever they had. You were a little bit quicker, but it took quite a while to go from Rome to Germany. Yeah, you had to cross the Alps, and that was a big hurdle already, right? Today, there are people who fly to some place around the globe almost on a weekly basis. I remember this in my company time. I was traveling like once a week to a place to meet people. So the number of humans increases, the number of animals increases, travel increases, and also there is new risk behavior. Let's start with the intensive care. If you get IV infusions, there is a risk for getting infusion-related infections. So there are new and increased exposures, and that results in additional infectious diseases. Or another example is sexual activity. Before there was a birth control pill, I'm very much sure there was not as many sexual encounters on a yearly or lifetime perspective as there is today. And when I studied medicine, we were taught there were three sexually transmitted infectious diseases: Today, when I talk about the topic, I stop at 10 because you cannot cover more than 10 in an hour in a meaningful way. In any event, the number of exposures increases. And finally, there are increased risks. And the risks come from the fact that we're aging. You see this here on the top. This is an aging society. Remember, almost all vaccines we have today were developed initially for infants. And only later on, we started developing vaccines for adults. So this has changed because we have an aging society. And this is why we need to change our view of vaccines and vaccination. We have to cover the elderly and we have to cover those with underlying diseases. The older you get, the more likely you're going to have an underlying disease. Actually, we know the numbers. When you're 60, 30% of the population, 60 plus, do have an underlying disease, and as of 65, it's 2/3 of the population. So this is really the reason with underlying diseases, you see with the same amount of exposure, you see an increasing number of infectious diseases. 3 reasons why infectious diseases increase. Melvin, maybe you have number 4, or can you think of anything else I forgot?
Yeah, so for me, I guess number 4 would be climate change, because you know, especially the vectors that we were expecting to be not seen in temperate countries, for example, in colder countries. Now we're seeing a lot of mosquitoes, and now we are reading a lot of dengue cases in Spain and some parts of Germany or some parts of Portugal. So I would add climate change.
Yeah, actually, that was my point number 1. Bullet point 3: climate change favors there are more microbes, right? I mean, I could make an extra point out of that, but I had this in here as more microbes. Yeah, but you may consider this is new exposures, right? Due to climate change. Yeah. In any event, I guess the lesson is learned. There will be more and not less. And you may ask yourself, why does he bring this up today? And the reason is, when I was a professor for the first time, the idea in Germany was infectious diseases are conquered. They don't play any role. We don't need to invest in anything with regard to vaccination, with regard to infectious diseases. We have some vaccines, we have antibiotics, that's it. We don't need to do anything else. And this was wrong, and we now know that it is all wrong, right?
Yep.
I have one other topic, and that is criteria for development of new vaccines. With new and more infectious diseases, we need to develop new vaccines. So how does this work, right? First of all, you have to identify a medical need. You have to see, okay, there is antibiotic resistance, there is whatever, right? You have to have a medical need. And I think this is out there. It was published by WHO, and Melvin will talk about this again today with these most infectious diseases from chikungunya and Rift Valley fever we will have today. So yes, there is a medical need for new vaccines. But you need more. You need to cover administrative issues. For your vaccine, you need a pathway to license. And that is often the main hurdle. If you have a great new idea for a pneumococcal vaccine that is independent of the capsular polysaccharides, you have a protein vaccine for the pneumococcus, you will not easily get a license because you would have to do a double-blind randomized study to show that the vaccine is working. You cannot do a double-blind randomized study because it would be unethical, because you cannot give placebo. You cannot expose somebody to the risk of pneumococcal diseases that may be lethal by not vaccinating him with available vaccines. So there is no pathway to license, at least not a very simple one. After the license, you need a recommendation. Very often, Europe is a late adopter. The pneumococcal conjugate vaccines took 7 years in Europe and in Germany to be recommended. Reimbursement, today, nobody has enough money for anything. It is really difficult to get money for new vaccines. And finally, there is vaccine hesitancy. You have to really make sure that the vaccine is used. If it is not accepted, even the best vaccine has no opportunity to really be of any good. Then you have to look at chances for success and risk. You need the resources. And here, what people don't see is You need to be a big company to get something on the ground globally. You need to know the licensing in 130 something countries. You need to know how to market it. You need to know the logistics and the cold chain. You need to know how to produce, and you really need to have a holistic view of all of that and get it done. Not a simple task, and it is very difficult for a small company to do this. This is why there are globally only 4, maybe 8 large companies that are global players when it comes to vaccines. And another reason for that is to do all this, you need at least 1 billion at risk with an overall failure rate of 90%. And your investment is gone if you fail in phase 3. In phase 3, you already need to have the factory, because the product for the phase 3 study has to come from the factory that will produce the vaccine for the market. So 1 billion is the benchmark that you need, and this is risk money. You may lose it. And then you certainly need to see, is there any money to be earned with it? And if there is no money to be earned, the vaccine will not be developed. Melvin, any views on or additions to my criteria of development for new vaccines?
I think it's very comprehensive. Just to emphasize the importance as well of the global economic political situation, which we've seen, for example, in the vaccine. It was first created by the Russian company, right? The Sputnik. The vaccine seemed okay, but it's not being used now because of what is happening in Russia. Yeah. And one thing as well is I can think of that is really important is, especially now in the age of social media, really making sure that the vaccine is accepted and understood by the community. And really just one simple mistake or one simple even fake news could sort of really destroy the confidence of people with your vaccine.
Yeah.
So, yeah.
I remember in Germany with the H1N1 pandemic, like more than 10 years ago, one politician said that the cell culture-based influenza vaccine was causing cancer. And that was the end of the vaccine in Germany. So this is, I mean, the media is really crucial here, right? And I wrote global economic political situation. Maybe I should add there something, or with acceptance, I should add something on media attention, because this is really a very important point.
Yes, mainstream media and social media.
Yeah. Now, going a little bit back to science, and as you said that the Sputnik vaccine is not used, although it seems to work quite well. For the Sputnik vaccine, the initial data was not transparent. We did not know anything about the double-blind randomized study, about this and that. The idea, the concept was really great. They used 2 different adenovectors to circumvent immunity to the vector so that the vaccine is still working. So I think the idea was great, but the communication was not good, and certainly the data was not out there, right? The question is, what data do you need to come up with a new vaccine? And that I covered here. First of all, preclinical, before you have any studies on humans, you have to have biological plausibility. What is the platform? What is your vaccine idea? And with that, you have to find an antigen, and you can think of what would I need to do to show that this vaccine is safe and efficacious. You look for animal immunity, you look if you need an adjuvant, you look if the animals get sick or if they even die. You read out your tests and you validate your tests. You need to develop new tests for the new vaccine to show that there is an appropriate immune response. At the time you start to think about your preclinical studies, you need to start thinking and planning your factory. If you have no factory, you cannot deliver, and building a factory in Germany may take forever with all the bureaucracy these days, particularly if you have some molecular biology items included. In Europe, it has become very difficult that some vaccine companies already think of moving to the United Kingdom or to other countries around the globe, because factory planning is no longer something easy in Europe. Again, biological plausibility is largely immunity and safety in animals. The next item you need is your clinical studies. Phase 1, you vaccinate maybe a dozen subjects first, and that may add up to 100 or 200. And you look how well is the vaccine tolerated and if it is safe, and you look at immune responses. Then in your phase 2, you increase the numbers, and then you have some thousand subjects, and you find the optimal dose. How much of the antigen do you need? And again, you look at, for the respective antigen you use, or for the amount of antigen you use, what is the local side effect? What is the fever rate? How much headaches do I have? So this is what you do with phase 2 on a large scale with some thousand subjects. This is all, let me say, just to see where do you want to go in the end with your phase 3. And the phase 3 is crucial. The phase 3 will determine what is in the label. You have to plan it in a way that you can see in the label what you did in your phase 3. You have to carefully select your endpoints. And in the end, a phase 3 means a double-blind randomized study with some 10,000 up to 80, 90,000 subjects. Actually, the largest trial ever was roughly 85,000 subjects, double-blind randomized. And you look for reactogenicity, safety, and efficacy in the target population. And you need to clearly define the endpoints here. And this is the crucial study that you do. This is proof of concept. You show that the vaccine is working and that there is no sign of unsafe events. You have to show safety as much as possible with the number of people studied. And then once you have your phase 3 data, you submit everything for license. You hope that you will get recommendations. There's nothing you can submit. You publish as much as you can, and you also have the license, and then you come down with your recommendations, and hopefully with reimbursement. Otherwise, your product is lost, right, if it is not paid for. And then you have to hope that it's used. And again, vaccine hesitancy is the big item here. And then finally, once you have license, recommendations, and reimbursement, there is phase 4. You look again for safety and effectiveness in populations around the globe. You show the impact of the vaccine. You show how much good is the vaccine doing in your target populations. Melvin, that is my evidence generation when it comes to vaccines and vaccination. And I trust you have comments here.
No, I think it's very comprehensive, Professor. And it's really important for people to understand that vaccines undergo a lot of all these rigorous testing, and the process is really robust before it actually lands into your arm for vaccination. It's not just something that you just do in the backyard and in the next morning you give it to people, you know. It is a long process. Yeah.
Yeah, actually, usually outside the pandemic, the process takes minimum 5 years. Usually it's like 10 years, right? Mm-hmm. And the funny thing is the people who had the idea for the vaccine very often are no longer around once the vaccine is used, right? Mm-hmm. Look, you start the vaccine when you're 50, you retire at 60, right? If you're a researcher, your life expectancy, your professional life expectancy is not as long in a company. And then in the end, you're gone by the time that the vaccine is on the market, right? Very interesting. All right. Thank you, Melvin, for your insight here. And now we're going to come to another pandemic, and that is monkeypox.
Yes. So, you know, we don't usually talk about monkeypox or Mpox because we don't really have a lot of news. But I think this is good to mention that even though the cases of Mpox continue to decline at the global level, activity is actually rising in the Western Pacific region of the WHO due to local transmissions in Japan, in South Korea, and in China. And also for the first time Pakistan reported its first case of Mpox, so we can also expect probably the numbers there to increase in the next few weeks or months. But as a global public health issue, the cases are already declining and tapering off.
Melvin, this is quite new to me. And looking at the date on your x-axis here, it is from March, and now we have early May. So this is 2 months old. Has this been known before, or did this really just pop up?
No, it was just reported. So it was a late reporting, and you know, especially in a case like monkeypox, right, where I think people are either not aware or probably people think that it's not there in the country. So the doctors or the healthcare professionals are not really thinking of Mpox when they see cases.
Very interesting. So my concern is that this was a hidden epidemic before it was made public, after it started to decline. Once it was under control, then that is when they started reporting it. But whatever, we just come up with the news as it is available. So
yes,
interesting. Thanks for picking this up. Melvin, I think we can now go to your most infectious diseases.
Yes, so we have been covering different diseases for the past 3 weeks now. So we have covered the Nipah virus in Global Healthcast 33. Then we had the Crimean Congo hemorrhagic fever in Global Healthcast 34. Last week for GHC 35, we covered Lassa fever. And today we will talk about the Rift Valley fever. So Rift Valley fever is a viral disease, and you will see on the next slide that this disease is mainly in some parts in Africa. It's a viral disease most commonly seen in domesticated animals in sub-Saharan Africa, such as cattle, buffalo, sheep, goats, even camels. People can get RVF through contact with blood, body fluids, or tissues of infected animals, or through bites from infected mosquitoes. Spread from person to person has not really been documented, so it's really a zoonotic disease, so a disease that you can get through animals. The virus is a member of the fleabovirus genus, and it was first identified in 1931 in a sheep epidemic on a farm in the Rift Valley of Kenya, hence the name. Since then, outbreaks have been reported in sub-Saharan Africa and North Africa. And in 2000, the first reported cases of the disease outside Africa came from Saudi Arabia and Yemen.
Okay. Very good.
Yes, and here you will see the basically where the virus is and the transmission, right? So as I've mentioned, people usually get this RVF or the Rift Valley fever through contact with blood, body fluids, or tissues of infected animals, or being bitten by mosquitoes. So unlike other diseases, I think this is actually there are lots of ways where how you can get infected, right? And this virus can be spread by the Aedes and the Culex mosquitoes, and of course the presence of these mosquitoes vary between regions, but environmental conditions, especially rainfall, is quite important as a risk factor for outbreaks in both animals and people. So Rift Valley fever outbreaks are most often linked to heavy rainfall and flooding, and because mosquitoes spread diseases, the disease is expected to really spread during the heavy rainfall months or seasons in a particular country.
So if I understand this right, the reservoir of the virus is in animals.
Yes, that's right.
And the vector are mosquitoes, And if there are appropriate conditions, the mosquitoes multiply. They suck blood from the livestock, and then they can infect humans. This is
Yes.
roughly the situation.
Well,
Okay.
that's one way. The other way is also for the people to just really be infected with the blood or fluid from animals
Okay.
without the mosquitoes.
Yeah. So by slaughtering the animals.
Yep, yep.
So basically, if the reservoir is in the animals, then there is an opportunity, there is the chance that the disease is eradicated or eliminated by, vaccinating livestock or. Is it only livestock or is it wild animals as well that carry the virus? That is the big question.
Yes, so I'm guessing that other animals, other mammals can also carry the virus since there are several animals that can do
Okay.
that, right? And so there is a vaccine for cattle, but of course, vaccination is not that widespread. And I would imagine that the other animals can still transfer the virus basically and act as a reservoir.
So it's a little bit like rabies. There is a wild reservoir,
Mm-hmm.
and there are human animals or domesticated animals. And the big risk really comes from the domesticated because we are much closer to them. And the
Mm-hmm.
mosquitoes that carry the virus, they infect themselves or they get the virus from the animals that are living close with us. And they also, the
Yeah.
mosquitoes then jump to us, right, as
So
humans.
so with your analogy, I would think it's like rabies and dengue because you can
Right.
have animals or the mosquito. Yeah.
Yeah. Very interesting. And now, what is the symptoms? What is the disease like?
Yeah, so the disease is actually quite tricky, right? Because the symptoms are not very specific. So you could actually not have symptoms at all. You could have mild illness with fever, weakness, back pain, and dizziness, which doesn't say anything. But it's important to know that 8 to 10% of people develop severe symptoms like eye disease, excessive bleeding, swelling of the brain, and these are the serious ones, right? In terms of prevention, um, cattle can be vaccinated, as I've mentioned. It's important to avoid direct contact with blood, body fluids, or tissues. It's important to cook raw meat and milk thoroughly to make sure that the virus is basically inactivated. And it's also really very important to wash hands with soap immediately after direct contact with animals. And this is not just for Rift Valley fever, but it's basically for all other pathogens. And it's really essential to protect yourself from mosquitoes and insect bites.
Thanks, Melvin, for this great summary. I've learned a lot. And one last question. I'm not sure if you know this, but is there any data to show what is the frequency of asymptomatic disease, or what's the percentage of asymptomatic versus symptomatic and severe? I mean, severe symptomatic, it's 8 to 10%, but
Yes.
probably no symptoms. It's difficult to find out how many are infected, right? That is the difficult part.
Yeah, it's difficult, but there are studies, although not a lot, to show that majority of people present with no symptoms in the initial stages. So that's what makes it actually tricky.
Yeah, it's a little bit like tick-borne encephalitis. Many are infected, few get the disease, and that may have to do with genetics
Mhm.
more than anything else or underlying diseases, right?
Yeah.
Thank you, Melvin. This was really great. Thanks for the insights and thanks for telling us about most infectious diseases. And with that, we come to the end of our Global Healthcast 36. We covered COVID-19 update numbers going down, but you have to look into details, and there is still mortality out there. We spoke about the monkeypox cases in some countries in Asia. So this is still around, and look at your local data, or if you're look at the country if you travel. I told you why infectious diseases will increase in the future, and that has to do with the number of exposures increasing, the number of humans and animals increasing, and finally with the changing population, with aging population and increasing number of underlying diseases. I spoke to you about criteria for the development of new vaccines. Having a new vaccine idea is today not an issue. give me the organism and I'll come up with a vaccine. The question is if it ever will get a license and if it ever will get recommended and used. And then I spoke about evidence generation for the development of new vaccines, and I spoke about biological plausibility, immunogenicity, and reactogenicity and safety. And I spoke about clinical phases 1, 2, and 3, where phase 3 is crucial for your license, and then phase 4 studies that are needed to show the impact of the vaccine in a population. Melvin then covered most infectious diseases, Rift Valley fever today, and that is some other, let me say, emerging disease. And I guess much more could be done to combat this disease, Melvin, if I look at it. So it's a little bit unfortunate that we don't look enough in these hidden infectious diseases. Thank you very much for listening to us today. You will find the presentation, the PDF of the presentation in our show notes. Please like, share, and leave your comments below. Thanks for joining us today. I am Joe Schmitt.
And I'm Melvin Sanicas. Thank you, everyone, for joining us. Stay safe. COVID is still there. Of course, as we've said, cases are decreasing, but it's still important to take care of yourself. And we want to end with this message that anyone can actually really catch COVID, even if you've been vaccinated or you've been infected in the past. But the outcome really depends on your age, your health, and your vaccination status. So please remember that.
Bye-bye.